In lieu of a vaccine for COVID-19, the medical community's been essentially grasping for straws, looking here, looking there, thrashing through historical literature, looking at what happened most recently with SARS and MERS to try and find something, anything that would give patients a better outcome. One of the issues that comes up when you're talking about a therapy, any therapy in any disease process, is that most therapies are a limited resource. So even after we cross the first hurdle of finding out exactly whether a treatment will give a significant improvement in a person's outcome, like this example specifically, of course, we're talking about COVID-19. If we find a therapy that gives a significant improvement in the outcome, the very next step is, okay, who should get it? Who benefits most? Because most of these therapies are going to be a limited resource. And one thing you don't want to do is use all of that resource on people who will have a full recovery from the illness without any treatment, and then not have that therapy available for people that will need it to have a significant improvement in their outcome, whether it be significant morbidity, heart disease, stroke, permanent lung damage, which we, of course, at this time, we really don't know how permanent or how long lung damage might last from COVID-19 for the people who have significant lung inflammation. But when we do know that those people have significant lung inflammation, or somebody has significant morbidity, and of course, mortality, we want to use that therapy for those people who will benefit most. So, okay, we got a therapy that works. Who should get it? An easy to understand example about limited resources and how those resources can and have been allocated is at the beginning of this COVID crisis. We didn't have enough reagent, enough testing kits to test everyone who came in with COVID symptoms. So it was there were federal guidelines, there were administrative guidelines for different clinics and hospital systems that directed us to test only those that were high risk and those that required hospitalization. Now, the efficacy of that from a containment standpoint, of course, can be debated. And it was clear that we could not do contact tracing and contact containment by testing only those who were high risk. But given that we just did not have the resources, that's all we could do at the time. Of course, now that we've caught up with the testing, we have enough reagents, we have enough testing kits, the cat's so far out of the bag that it's almost impossible to do contact tracing and containment at this time. Okay, so we have the question answered about whether therapy works, what is that therapy, and who should get it. The very next question is, when should they get it? I mean, that's a very important question. Okay, so this is where we pick up the story about convalescent plasma as it relates to the treatment of COVID-19. First of all, there's no 100% evidence that giving convalescent plasma, antibody-rich convalescent plasma for COVID-19 patients gives a significant improvement in the morbidity and mortality of patients who have been affected by the coronavirus. Let's get that out of the way right up front. But in my opinion, I cannot see how it would be harmful. So if we go back to the Hippocratic Oath and we talk about what is the first thing that comes on the Hippocratic Oath? It says, first, do no harm. So once we know that a potential therapy probably won't harm a person, I really don't have a lot to lose. So what is convalescent plasma and what does it do?
With stirring motion, I mix the potion that gives us our mental power.
We begin with the prenup, an intro to the info. I'm itching to get distro. This is just a window in the world of Dr. Lingo. Flash and slice a disco. Ideas come in like disco. The name is Common Sense, though. Not to keep this rapping, bro. This is what you don't know. I bet it's just a bro. Take it away from the show.
So first, let's back up and talk about what the immune system does when it sees that you have an infection, whether it's a virus, a bacterium, a fungus, whether it's allergies. Well, the first thing that happens is your immune system has to recognize that there's an invader. It's like the Death Star in Star Wars, right? And the rebellion or the resistors, they've come onto the Death Star. Well, first, the stormtroopers have to even recognize that they're there, right? Once they recognize that they're there, then they can mobilize the troops, right? Then they can attack them. So first thing that needs to happen is your body is the Death Star in this case. Your immune system is a stormtroopers walking around. They need to recognize that there's an invader. Once they recognize the invader, then they can mobilize the troops, which is they can get the immune system kind of cranked up, revved up, and start attacking that invader. But that doesn't happen right away. And there's a lot of factors that can kind of play into whether an immune system is readily available to recognize that there's an invader and get everything mobilized, or whether they've been weakened or even distracted. And this is when comorbidities really come into play. So somebody who's morbidly obese is in a state of chronic inflammation. So their immune system's kind of revved up at a kind of low grade inflammation at all times. So their immune system essentially is kind of distracted. So when an invader comes along, they're really not all up to the task of taking care of it right away. It's one of the reasons that people who are morbidly obese don't do well with infections. Diabetes is also a state of chronic inflammation that essentially kind of behaves in the same manner. And of course, if a person is immunosuppressed because they're on chemotherapy, they have HIV, they have immunomodulating agents that they're taking, whether it be a steroid or an immunomodulator for inflammatory bowel disease. All of those things can impair the stormtroopers from seeing there's an invader and immobilize the immune attack. Hence, there's a great variability in the timing of an infection and an immune response from individual to individual, from days to even several weeks. And that's dependent on all of these different factors. So an immune response is not just composed of antibodies, but it's also composed of like T cells, macrophages, B cells. It really just depends on the type of infection it is, which one really takes the lead as far as like which stormtrooper takes the lead in protecting the Death Star being your body, stormtrooper again being your immune system. Either way, it takes some time for them to recognize that there is an infection, mobilize the correct troops, and get started with taking care of that invader. The whole point of me telling you this convoluted sort of long story about Star Troopers and Star Wars and the Death Star as it relates to the immune system is so we can talk about vaccines, really. So getting an infection, having your immune system recognize that infection, mobilizing the troops, or getting a vaccine, both are considered active immunity. What that means is that your immune system has been mobilized to create antibodies, to have T cells and B cells, macrophages recognize an infection and attack that invading infection and get rid of it before it causes significant damage to your body. Now, a vaccine is meant to do that before you get an infection, and then your body, your immune system, will have some memory of that infection for a various period of time. And that period of time varies from one vaccine to another or one infection to another. But that is active immunity. Convalescent plasma, on the other hand, is what's called passive immunity. So what you're doing is you're taking antibody-rich plasma from someone who's already developed active immunity from an infection so that they have high antibody titers. You're taking that plasma, which is a part of the blood, someone's blood minus the red blood cells and platelets. You're taking it, infusing it into a person to give them passive immunity before their immune system has the chance to respond and develop its own active immunity. In our stormtrooper example, the analogy would be like if there was a third party, another group of space travelers who had a planet somewhere, and the resistance or the rebellion had already attacked them before, and they came to the Death Star prior to the Death Star getting overrun by the rebellion, and they went up to the stormtroopers like, hey, look, there's some guys here from the rebellion. We've seen them before. We've defeated them before. Let me show you where they are. We're already fighting them off a little bit, but let me show you what to do. That would be convalescent plasma. So the proposed mechanism of action for antibody-rich convalescent plasma is that those antibodies will bind to the receptors on the viruses, preventing those viruses from interacting with cells, enveloping into cells, and then replicating inside of cells, and thereby causing cellular damage. In addition, those antibodies then facilitate the phagocytosis of the virus by macrophages, which macrophages, if you think about it, basically like little Pac-Mans. They come and they just eat up viruses and prevent them from enveloping into cells, the host cells, which is people's cells, and causing that cell to replicate the virus and then cause cellular damage, whether it be in a case of COVID-19 in the cardiovascular system and in the lungs. So the hope and the promise of convalescent plasma is that you would confer passive immunity before there is significant damage to a person, right? Makes sense, right? But here's the rub. Up until now, the date today is September 1st, there's really been no studies to look at giving convalescent plasma to a cohort of high-risk individuals that would most likely benefit from convalescent plasma before they have significant disease. Right now, the only way you qualify to get convalescent plasma is if you're sick enough to be hospitalized, which by definition means that you already have a significant inflammation. You already have an immune response. You have an active immune response that's already happening. To me, that just really doesn't make any sense. Based on the proposed mechanism of convalescent plasma, the most effective regimen for administering convalescent plasma would be to do it before a person has significant symptoms, before they have organ damage, before the immune system has started to confer active immunity and you've set in with significant inflammation that causes the organ damage. Without doing that, without studying that, we will never know if convalescent plasma is really effective in preventing significant morbidity and mortality. I mean, we may see some improvement in some patients, but we won't know the full effects of what it could potentially do in the treatment regimen for COVID-19. Now, I do get it. I understand why we are sort of using this experimental treatment on people who are already sick for various reasons of limited resources, of potential for harm, although in my opinion, I think the potential for harm is extremely low. But mainly, I think it's because of the limited resource of convalescent plasma. I mean, you have to take someone who has been sick with the disease enough to have a significant antibody titer. You have to get those people to donate plasma, and they have to do it within a certain amount of time where their antibody titers are high. And then there's a time period in which that plasma has some efficacy and has to be administered, and once it's administered, you really don't have another chance to give it to another person. So I do get it. But at the same time, we kind of know, it's been 6 months since all this began. We kind of know who's going to not do well for the most part. We know who that cohort is. I think it's time for us to really move forward. Try convalescent plasma on patients very early on in the disease process. For those individuals with significant comorbidities that we have already seen don't do well, and do some serious study, possibly even a randomized study, to determine what efficacy convalescent plasma will have on the morbidity and mortality in the COVID-19. Don't forget to subscribe to be notified when we drop new Dr. Keith episodes. And please post any questions you have about this episode or any other medical questions in the comments.